Okay, so we're going to go through chapter 18. I also have chapter 24 and some stuff from chapter 22 for us to cover. I'm not sure if we'll get to 23, but we're going to try. All right, so we're going to start with chapter 18. This is management of the newborn. Last week we did chapter 17. So true or false, an Apgar score of 8 or better is a normal finding for a newborn.
True.
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 Okay. What's not normal?
Under 8.
Okay.
I think below
Under 8 meaning what?
I believe
Below 7.
below 7.
Okay. So how often do we check the Apgar score?
The first 1 minute and then the next 10 minutes.
Okay,
Or
so we
5
do
minutes.
it at 1 minute and 5 minutes, right? And then
Yeah.
we do an additional one at 10 minutes if the score is less than 7. So 0 would be either an absent or poor response. 2 points would be a normal response when we look at those different criteria that's on there, right? And then the normal score should be 8 to 10. The higher the score, the better the condition of the newborn. You want to know how to do these Apgar scores, okay? We're going to do a couple of questions on them as we go through, because you definitely want to know how to calculate these. All right, an extremely low birth weight newborn weighs less than 2,500 grams.
No, that's just low birth weight, right?
Okay, good. Newborns are classified by the birth weight regardless of their gestational age. Low birth weight would be less than 2,500 grams or less than 5.5 pounds. Very low would be less than 1,500 grams or less than 3.5 pounds. And then extremely low would be under 1,000 grams or less than 2.5 pounds. Oh, you got the answer there. Immediately after birth, a newborn's mouth is suctioned first and then the nose. Better not get it wrong. Since I put the answer up there already. All right, true. Why?
Risk of aspiration.
Okay, why is there a risk for aspiration in the mouth versus the nose?
Is it because they're nose breathers?
Because remember when they come out, how do they initiate those respirations? What happens there? They take that big gasp of air, remember?
Yes.
So when they take that gasp, that puts them at risk if they have mucus or anything in the mouth for them to aspirate. Acrocyanosis is normal and occurs intermediately in a newborn. Is it normal or not? Acrocyanosis. What is it, first of all?
Oh, it's normal when they have.
Extremities being blue. And then body. Okay.
Okay, so we have this cyanosis that's persistent of the hands, the fingers, the toes, the feet. The skin might be mottled, blue or red, and cold, called acrocyanosis. And it's seen in babies in the first few weeks of life, and it's usually a response to exposure to cold. Now, it is normal and intermittent. What should we see as far as like the body of the baby? Should that be blue and cyanotic too, or cold?
No. No.
All right, so it's just going to be the extremities, right? Just the
Extremities.
fingers, the hands, the feet. A newborn's chest circumference is usually 1 to 2 centimeters larger than the head circumference. True or false?
False.
Okay, what's the true statement?
It should be smaller.
Smaller, yes, less than the head circumference. Good. How about the abdomen of the baby? What does that usually appear like? So we call that
A little distended but soft.
protuberant without being distended, and it might have a dome-like shape. Nevus vasculosus, also called a what?
Is it strawberry?
Strawberry. This is that strawberry hemangioma. It's a capillary hemangioma. It lays in that dermal or that subdermal area. And it usually will look like this raised, rough, dark red area. It has really demarked borders. So it's distinguished. You can see it. It sticks out from other things. And it usually resolves by the age of 3 without any issues. Which fontanelle is triangular?
The anterior,
The what?
Posterior.
Posterior?
the anterior is diamond shape, right?
Okay, the
It's
anterior is
posterior.
diamond shape. Yes, the anterior is diamond shape. Put the diamond in the front. That closes between 18 and 24 months. It usually measures between 4 and 6 centimeters at its largest area. So that's bone to bone. The posterior is triangular. It's smaller, usually about 0.5 to 1 centimeter, and it generally closes between 6 and 12 weeks. What reflex is also called the embrace reflex?
Is it startle?
Yeah, the startle, the Moro. The Moro reflex is the embrace. All right, and it's also going to happen when that baby gets startled. So if you drop a loud something, but we check this in the baby by lifting the baby up a little bit off of their back, and then we just sort of drop them a little bit. We still catch them, right? Because we don't want that neck and that back to slam down on the crib. So we'll just drop them a little bit and we catch them, and they should be startled a little bit. And what is that thick, tarry, sticky green stuff that the baby passes within the first 24 hours after birth?
Meconium,
Good, meconium. All right, so right after the baby's born, the first thing you're going to do is you're looking at the general survey of the baby, the symmetry. So when we talk about symmetry, is everything equal on one side like it is on the other? The chest rises and falls equally. The arms, the legs move similar. Any obvious deformities? We're looking at that size. If the baby's too small, then it's more at risk. Also, if the baby's too big, it can be at risk, right? So what kind of things would we look at with the small baby versus a big baby?
The head, right?
Okay, so with the big baby, we really got to look at the head and shoulders to make sure the baby came out safe, right?
Mm-hmm.
What else with the big baby? Who are they usually born to?
Maternal diabetes, gestational diabetes.
gestational diabetes mothers.
Okay, so we're gonna have to watch for episodes. Of course, we watch all babies for episodes of hypoglycemia, but these babies might be a little bit more susceptible. And so might your preemies, right? Because your preemies also, we have to worry about things with them. Now with preemies, we tend to worry more about what?
Respiratory and
Respiratory,
hypoglycemia.
good, because those lungs aren't quite developed or they might not have that surfactant.
Mm-hmm.
So just basic things you want to think about. We're looking at the baby's muscle tone, how well they hold their posture. What sex are they? Of course, everybody wants to know that as soon as they come out. And then how's the baby engaging? Are they crying, lethargic? Are they responsive? We take a look at these protective reflexes that they have. And jitteriness. Jitteriness can also tell us a few things about the baby, especially hypoglycemia and things like that. You would also want to look at the respiratory status, right?
Yes.
What would indicate a respiratory problem in this child? So we're looking at things like nasal flaring, grunting when they exhale. Babies are nose breathers. We look at their body to see if there's any flaccidity or floppiness. They should be able to hold some sort of tone, and that may develop more as they're here on the earth. Abnormal breath sounds, abnormal respiratory rates. So in order to know abnormal, you have to know normal. Abnormal heart rates and abnormal newborn size. Now, what are some things that you might hear that you would expect to hear, let's say with the respiratory system? What rate would you expect it to be, and what would you expect those respirations to look like? Come on.
So respiration is like 110 to 160.
Okay.
That's the heart rate, right?
That's the heart rate. Thank you. Sorry.
Sorry,
Yeah.
you're right.
So it's
That's the
30
heart
to
rate.
60, right? Irregular?
Respirations 30 to 60, heart rate would be 110 to 160.
60.
How would the respirations be?
It's irregular, right?
They're a little irregular. Any apnea?
Yes.
Yes.
Okay. When would we be concerned about that apnea?
If it lasts longer than what, 20 or 30 seconds?
15 seconds. You might see a test question about that. Anything over 15 seconds, we have to be concerned about. So things that we're going to do is we're going to start the exam with the least invasive elements possible. So we would be listening to the heart and the lungs. If the baby's crying or upset, we're going to postpone that. We need the baby to be calm. We're also going to get an apical pulse. Before you put that stethoscope on the baby, what are you going to do?
Warm it.
Warm it.
Warm it up. Besides the apical pulse that we're going to get when we listen at that fourth intercostal space for a full minute, okay, we're going to also look at the rate, the rhythm, and any abnormal sounds as murmurs. Now, what if you hear a murmur in a newborn? You're going to call the doc right away?
No.
It's
Why?
normal a little bit.
Okay. Heart rate. Typically, it'll be like 120 to 160 when they come out, but then it's going to level out to about 120, 130 after they're out for a little bit. We're also palpating the apical, the femoral, the brachial pulses. Remember, we're always comparing one side to another to make sure that they're equal strength, equal rate. All that has to be equal. And then we're looking at any abnormalities and we would report them. For respirations, you're looking at the rise and the fall of the chest. Now with babies, I don't care if it's heart rate, respiration, you're doing it for a full minute. They have to be, these respirations have to be symmetric, slightly irregular, shallow, and unlabored between 30 and 60. And then anything over 15 seconds as far as apnea would be reported. Anything that would show like full body cyanosis would have to be reported and addressed. So the acrocyanosis, remember, is not going to include the body. You're also looking for tachypnea, bradypnea, grunting, gasping, any decreased chest expansion, any rhonchi crackles, or sternal retractions. So usually you can tell if the baby has retractions because you'll be able to see the ribs It'll suck in around the rib cages and around the sternal area up around the throat. Apgar score. All right. So this is influenced by a few things. It can be influenced if mom or the baby has an infection, if the baby's not mature, if mom's very old or very young, if the baby has any congenital issues, if the baby is not of the appropriate birth weight. So remember, the baby has to be within that certain parameter on the growth, on that growth chart. Any meds that mom might be taking or that the baby received during labor or mom. Any neuromuscular disorders. Any physiological immaturity. Length is measured from the head to the heel with the baby unclosed. And we also have to put the baby in a supine position and extend the leg. And that's because of the baby's natural flex position. Why do they have a flex position? What did they use that for? We talked about this last week. Remember that flex position and that brown body fat helps them maintain what?
Heat?
Yeah, their body temperature. All right, so the baby should be about 17 to 22 inches or 45 to 55 centimeters. And if the baby has molding, that can affect their length. Why?
Does it make them longer, maybe? I don't know. Their head is molding is when they have like a cone head, right?
Exactly. They have that cone head. Good job. They have that cone head, and so that makes them appear longer than what they are. Because remember, we're going from head to toe there. All right, then we weigh the baby normally using a digital scale that weighs in grams. So typically the baby should weigh somewhere between 2,500 and 4,000 grams, or between around 5 to 8 pounds. Remember that babies can lose about 10% of their initial birth weight within the first 3 to 4 days. So if you go out to do that mom home baby visit, you might see this. The baby's lost a little weight, as long as it's not more than 10%. And typically they'll gain that weight back within the first 10 days. Now, why do they lose that weight?
Is it the extra fluids and stuff?
Good.
Or that's the mom?
Cellular fluid, the meconium is going out, and they have a limited amount of food intake because their stomachs are small, so we have to get them adjusted. Remember, the first few hours, the stomach is not really going to stretch. Gestational age tells us the stage of maturity. So we look at a couple of things for that. We look at physical signs, which would be things like the texture of the skin, the lanugo, the creases in the plantar area, the breast tissue, the eyes, and the genitalia. For neuromuscular, we're looking at the posture, something called the square window, the arm recoil, the popliteal angle, the scarf sign, and the heel to head. I'm sorry, heel to ear. So we use something called the Ballard Score. And it helps us determine the newborn's gestational age between 20 and 44 weeks. This provides us an estimate of that gestational age by looking at the physical and the neuromuscular maturity. Points are assigned for each area. with a score of 1 to 2 points for extreme immaturity and 4 to 5 points for those babies that have been in the oven a little bit too long. All right, so again, physical maturity is assessed within the first 2 hours of birth. They use the Dubowitz-Ballard exam that looks at the baby's gestational maturity. Points, again, are given based on how mature the child is. So the higher the level, the more mature. And then, of course, when you get really high, then we're talking about post-maturity. So what do we look at? Skin textures. Is the skin sticky, smooth, or peely? And we'll see a couple of those in some pictures as we go forth, right? We look at the lanugo. What is that?
That's
That's the
defined here.
fine hair that covers the baby.
Good. Immature babies don't have it. Normal babies within that normal 38 to 42 weeks will have it. And then it goes away again as the baby stays in the oven a little too long. So after 42 weeks, that hair is going to go away. The plantar creases. These are on the soles of the feet, and they can be absent or they can cover the entire foot depending on their maturity. Breast thickness. The thickness and size of the breast tissue and the areola around the nipple are assessed. Eyes and ears we also look at. And we look at whether or not they're fused or open. The amount of cartilage and stiffness of the ear tissue are also noted. Also, ears and kidneys are developed around the same time. So a lot of kids that have like genetic or metabolism issues, deficiencies, will have ears that are either offset or low set, or ears will have some sort of issue with them. The genitalia for the male, we look for the testes, for the appearance of the scrotum. We look to see if it's smooth or wrinkled. And for females, we look at the size and the appearance of the clitoris and the labia. For neuromuscular, we look at posture. This is how the baby is able to hold their hands and their legs. The square window, and this is how far the baby's hand can be flexed towards the wrist. The arm recoil. This is how far the baby's arm will spring back into a flex position. The popliteal angle. That's how far the baby's knees are extend or will extend. The scarf sign. This is how far the elbows can be moved across the baby's chest. The heel to ear. This is how close the baby's feet can be moved to their ears. And then we add those two scores together and we get the gestational age. Now, if the baby has a low birth weight, then the score might not be accurate for a normal baby, but it might be accurate for a preterm baby. All right, so if you look at these here, these show you the postures and the numbers assigned with them. 2, remember, is when you're flexing that hand that towards the wrist. And then we have the arm recoil, the popliteal angle, the scarf sign, bringing the baby's heel to the ear. And then the physical maturity. So you see the skin, it'll be sticky if the baby's immature, cracking if they're post-mature. If they're normal, it should be smooth, pink, and you should be able to see through it and see the veins. With that lanugo or that hair, it'll be abundant in the normal baby and scarce in either the post-term or the preterm. The difference between the preterm with this hair is you may not see any hair, whereas with the post-term, you may see areas of hair, but then bald areas where the hair is like missing. The plantar surface in the normal baby will see faint red marks. In the post-term, those creases will be all over that foot. And then in the preterm baby, you may not see any of those creases or very little. And then the breast in the preterm baby, it won't be that easily seen. In the normal baby, they should have an areola, but no budding. And then in the post-term baby, you'll see an actual budding of the breast a lot of times. The eyes and the ears. So the lids can be fused together in the preterm baby. In a regular baby, they would be slightly curved. The pinna would be soft. In the full baby, the cartilage of the ear is going to be thickened. And then for genitals for the male, the scrotum will be flat and smooth. It will start to have some rugae in the normal baby. Sorry, flat and smooth in the preterm. And then they may have deep rugae in that baby that's post-term. And then for females, the clitoris will be prominent with the flat labia in the preterm, prominent with the enlarging minora in a normal baby, and then the majora will cover the clitoris and the minora in the full term or post-term baby, in the post-term. So what does Apgar score really look at? What's the most important of the Apgar score?
Heart rate.
Heart rate. Okay, so it's looking at these 5 signs: the baby's color, the heart rate, the reflex irritability or the grimace, the activity, which is their muscle tone, and their respiratory effort. So each parameter is assigned that score from 0 to 2. 0 indicates an absent or a poor response. 2 indicates normal. And normal baby should be between 8 and 10. The higher the score, the better the baby. If it's 8 or higher, no intervention is needed other than normal respiratory support and normal thermoregulation support. And again, you know, like we talked last week, whenever they're asking you about the baby, no matter what you're doing, you're always making sure that the temperature is regulated. Score of 4 to 7, moderate difficulty. 0 to 3, severe distress. It's influenced by things like infection, mom's age, the baby's maturity level, any congenital issues, the weight, any medications baby or mom might have received, labor management. When the newborn experiences physiological depression, the Apgar score characteristics disappear in a predictable manner. First, the pink color is lost, then the respiratory effort, then the tone, followed by reflex irritability, and then the heart rate. All right, so make sure that you're also monitoring those vital signs. These are what you should be seeing in these babies. Nurses checking a newborn 1-minute Apgar score based on the following assessment. Heart rate is 160. He has positive respiratory effort with a vigorous cry. His muscle tone is active and well flexed. He has a strong gag reflex and cries with stimulus to the soles of his feet. His body is pink with his hands and feet cyanotic, which is the newborn's 1 minute Apgar score.
He's a 7.
Does everybody think it's
A
a 7?
9. 9.
Okay, good.
Mhm.
9. Why ain't you clicking? Okay. All right, 9, because of heart rate, respiratory effort, muscle tone, and reflex irritability all have a score of 2, and color with the score of 1 because of the acrocyanosis. Everybody get that one?
Yeah, I'm just trying to see which I didn't count. It's something I didn't count on there.
Okay,
Because
go
I
ahead,
did
look.
count 1
Take
for
your
the
time
feet.
and look.
I counted the heart rate. Respiration.
So the heart rate, respiration, activity, cry.
Uh-huh.
Yeah, so it should be 4. So 5 in all. So I think you left out 1.
Yeah, I left out 1. I don't know. Maybe the gag reflex. I think I left out. That would be 2.
And then
Or
there
is it the muscle tone? It's something I didn't.
Everything was 2 except for the color.
The color I counted that as 1. Okay, but it's fine. I understand it, so it's okay.
That's
You
okay.
can
We're
go on.
going to do another one right now.
Okay.
You're assessing the 1 minute Apgar score of a newborn baby. On assessment, you note the following about your newborn patient. Heart rate 101, cyanotic body and extremity, no response to stimulation, no flexion of extremities, and strong cry. What is your Apgar score?
So we'll say heart rate 101, that is below. Oh my God, that was 1. Cyanotic body, extremity 0, no response 0, strong cry 2. So like, we'll say probably 4. So 4, 2, 3, 3.
You were right the first time, 4.
Yeah.
Okay, we're good with that one.
Yes.
All right, so then you're going to do this RAP assessment. So what exactly is this? We're looking at the respiratory activity, the baby's color and perfusion, their position, their tone. This helps us quickly evaluate the condition so that we can make decisions about their stability. All right, we'll do a second one of these in the first 2 to 4 hours, and another one when the baby's admitted to the nursery or the labor and birthing room. The third assessment is usually completed before discharge according to policy. And again, it helps determine the overall status of the baby. I'm going to put you guys on mute because somebody's snoring. When you want to talk, you can just press the space bar and it'll let you talk. All right, so Always make sure you maintain the patent airway. Keep that bulb syringe nearby. The baby can develop a chokage or, something that would block their airway or cause them to choke at any time. Proper identification, why?
So the babies won't get mixed up, and so that, like, I guess, so babies won't be kidnapped from the hospital.
Abduction is the big thing now. So we have to look at that, okay? And then thermoregulation, which they're not gonna ever stop talking about with these babies. All right, so immediate period after the baby's born, we're focusing on the baby's ability to transition to this life outside of mama, the extrauterine life. So we have to maintain that airway, make sure that mom, dad, brothers, sisters, the baby all have those proper identification tags. We're maintaining the temperature of the baby. Remember, so we're avoiding things like conduction, convection, evaporation, radiation. You need to know what they are, how would they affect the baby? And we may have to administer medications if any are prescribed. So what are we suctioning first?
The mouth.
The mouth,
Okay, and then
the nose.
the nose. And we do that because it prevents
Aspiration.
aspiration. Now, you might see like some things in your book that say that sometimes they don't suction babies anymore because sometimes it can be more of a risk than a benefit. All right, you're just going to go with what your policy is as far as the hospital. Abduction continues to be a threat in hospitals. So we have to make sure that anybody in the hospital has the proper identification, including staff. We do have surveillance systems in there now. And usually there's a security code that most hospitals will use called code pink. So if a baby is abducted or they suspect that something's going on, they will call the code pink. Before the baby and the mom can leave the birthing area, typically the mom, the baby, dad, and any significant others that they include would receive a bracelet, and the baby would get 2 bracelets, one on the wrist and one on the ankle. Remember, these babies are going to have a problem regulating their temperature, especially in those first few hours. So we will use a radiant heater to help the baby prevent loss of heat. So that's what those little rolling cribs are. A 1-day-old baby should have enough thermoregulation to remain out of the radiant heater. Once they've gotten the heat the first day, then they should be okay with just the skin to skin and mom's holding and wrapping. But once, if the baby's premature, they may not have that same ability. Now you're going to assess the temperature frequently during the immediate newborn period, every 30 minutes for the first 2 hours until it's stable, and then every 8 hours until discharge. And how do we check that temperature?
The axillary.
Okay, you can use the axillary. Where else could you place the thermometer? Over the liver, right?
Oh, okay, I saw that.
We talked about that last week. You could put the baby on the side and put it over the liver. All right, we went over this pretty well. Anything else on here you guys need me to repeat or you're not sure about? This is about the Apgar score, about the length, how we weigh the babies. We're good with all that?
Yes.
Gestational age is the next thing we're going to talk about. All right, so a preemie is considered any baby born before 37 weeks. At what age is the baby usually viable?
Is it 28?
They can actually save them at around 23 weeks. My nieces were born the day of the very first day of the 23 weeks. They were triplets. And they were actually trying to come on day 22, like the end of the 22nd week, on that final day of the 22nd week. And the doctors told them clearly that if the babies were born before midnight, they wouldn't try to save them. But if they were born after midnight, they would do everything. Luckily, they came after midnight. All right, full term, 38 to 42 weeks, and then post is anybody that stays in that oven after 42 weeks. After 42 weeks, we're going to see aging of the placenta. So what does that mean? What happens when that placenta gets old?
The baby's not gonna get enough nutrients and oxygen.
Okay, good. We have some babies that'll be born at small for gestational age. So these babies are less. They don't fall within that 10 to 90th percentile. And then large for gestational age, they'll be above the 90th percentile. So these things we assess this gestational age because it allows us to try to figure out how the baby's going to grow and anticipate problems that the baby might experience because of some premature, post-mature, or growth abnormality. Again, we look at physical maturity, we look at skin texture, okay? So skin should be what for the normal newborn?
Smooth.
Smooth, pink, thin, and we should be able to see the veins, right?
Yeah.
What about for the preterm? What's it gonna look like?
Slimy and
Might be a little sticky. How about for the post-term?
dry.
Dry and pilly. Okay. How about that hair? Who's gonna have hair, who's not?
Like the lanugo or the regular hair on the head?
The lanugo, that is the regular hair. Like not the hair on their head, the lanugo, sorry.
Oh,
Pre
so
and post won't have.
Okay, pre and post won't have. Pre will be sparse, post will be balding, and the normal baby should have it throughout the body. How about the plantar? The plantar creases, how about those?
no creases for the term, or some creases for the preterm, and the normal will have creases, and I think the post term will have, it will be covered, right?
Yeah, excessive creases covering the entire foot. How about the breast tissue? So just remember, as the baby grows, it's going to develop more and more, okay? Preemie would have really none or a very small amount. A full-term baby, you could see like the nipple and the areola, but not necessarily budding. And then with that full-term baby, you're going to see a little bit more of the budding. And then how about the eyes and ears? What are we going to see there?
In the post term, it'll be wide and eyes. Oh, in the preterm, you said stuck together a little bit.
It feels
Okay, good.
too.
Full term, we should just see the eyes open, right? They might be a little more wide with the post term, and the ear is the main difference, right? We're going to see the stiffness in that cartilage as the baby grows older. So when the baby is preemie, they might not have a very good shape to the ear. Normal, they should have like soft cartilage that's showing a nice shape. And then post term, the cartilage is going to become a little more stiff. All right, and then how about the scrotum for the male?
Preemie is Non-distended testes or
Smooth. You know, testicles have like that rugged on them. You know what I'm talking about? They have like that roughness. Is that what-
Yes, smooth and
Okay.
flat.
Yeah, so the preemie will be more smooth and flat. They'll develop a little rugged in the normal baby, but in a post-term baby, it'll be excessive rugged, deep. And then for the female, remember the clitoris
Flat,
will be
flat
very
labia.
prominent. Clitoris will be very prominent in that preemie. In the normal baby, you'll have a little combination where the clitora and the labia majora are sort of like the same size. And then in the post-term, the majora will sort of cover up the clitoris and the labia minor.
Okay.
I'm gonna go ahead and put these videos. I think these, oh, it wouldn't let me. I was gonna put these in the chat box for you guys. If you guys watch, I think you can still access both of these videos and they're pretty good. They go through like going through these little routines with the baby, doing the posturing, doing the square window so that you can actually see it and make a better connection to it, okay? I'm not gonna play it now because it's gonna be time consuming and it's something you guys can do on your own to try to understand it. Just remember that posture looks at how the baby holds the arm and legs. When we're talking about square window, we're taking the baby's hand and we're flexing it towards the wrist. The arm recoil is looking at how far the baby's arm springs back into a flex position. The pop ledal looks at the baby's knees while they're extended. The scarf sign, we take the baby's elbow and we try to move it across the chest. And then heel to ear is where we're bringing the baby's feet up to their ears. So we do this all the time when we're playing with the baby, right? But that's actually a measurement that they look at that tells about maturity in the baby. Is the following statement true or false? Arm recoil is a measure of assessing the baby's newborn's physical maturity. True. Okay, it's false, right? Arm recoil is neuromuscular. Remember, physical signs are going to be like skin, lanugo, genitals, ears and eyes. Those would be your physical. Your neuromuscular will be the scarf, the sign, the heel to ear, the pop ledal angle, the arm recoil, the square window, and the posture. All right, so again, physical signs, which is what they're asking about here, would be skin, lanugo, those plantar creases, the breast tissue, the eyes and ears, and the genital. So what are you going to do for this baby? One, you're going to make sure that they have a proper airway. And how are you going to do that? How are you going to make sure they have a patent airway?
Suctioning
Suctioning what?
the mouth and the nose.
The mouth and then the nose. How are you going to maintain thermoregulation?
Keep the hair covered, keep them warm.
Okay, what else? What's the biggies when they come out?
Kangaroo.
In the
Skin to
skin.
skin.
Okay, dry first, then skin to skin. Wrap them in blankets, put them on the scale. You got to cover it first. A hat. We don't give them full baths, right?
Mhm.
And we use that radiant warmer, making sure that, you know, everybody's got proper identification. So nobody's taking the baby that doesn't deserve the baby or shouldn't have the baby. How about medications? What are we given and why?
We give them erythromycin to prevent infection in the eye, and we give them vitamin K for clotting vectors.
Okay, what kind of infection are we trying to prevent in the eye? Why would they get an infection in the eye?
From vaginal
After the
secretions like
birth canal.
Okay, good. Exposed to those vaginal secretions in the birth canal. Mommy's been a bad girl. All right, so she's got this STD and the baby's at risk for it. So all newborns in the United States must receive that prophylactic agent in their eyes within an hour or two of birth, mandated in all 50 states to prevent ophthalmia, neonatal, who wants to say it? Ophthalmia neonatorium, which can cause blindness in the baby if we don't treat it. All right, so that's the major reason there. This is a acute condition. It causes a purulent conjunctivitis during the first 10 days of that baby's life. And it is caused by coming in contact with those vaginal secretions of mom who has gonorrhea or chlamydia. The eyelids will become swollen and red with that purulent discharge. So erythromycin is one of the main drugs that we use here. For vitamin K, when does the baby's body start to develop vitamin K?
They eat.
Once they eat. So it takes about 24 hours sometimes, right? So the fat soluble vitamin promotes blood clotting to increase synthesis of prothrombin by that liver. Remember, the liver's a little bit immature here still. And there's a deficiency of the vitamin. So that would delay clotting and could cause a hemorrhage in the child. And you have to think, like, some of these babies are born with things like hemophilia, and there's a couple other blood clotting disorders, Willebrand's, von Willebrand's. These babies could bleed out. So you want to make sure that they get this vitamin K. All right. The vitamin K is produced in the bacteria. However, the newborn's bowel is sterile. So the vitamin K is not produced until after organisms are introduced to it. So that's why we have to wait until after the first feeding before those microorganisms will start to be introduced. All right, so we're maintaining that body temperature. Again, you're going to hear that over and over. That's the main thing for this baby. Skin is thin, blood vessels are close to the surface. They don't have that much sub-Q fat. They have 3 times the body surface of an adult, and they're susceptible to heat loss because of the tone in the skin being poor and the lack of fat and the thin skin. Those 3 things. That can occur if a wet surface is exposed to air. So this happens when the baby comes out and they have that amniotic fluid on them. So we dry them, we do that skin to skin contact. It can happen when we touch the baby with our stethoscope or put the baby on a cold scalp. So we have to warm items that we touch the skin with or put a barrier between the baby and whatever object you're going to put them on. So that barrier will be something like a blanket. Convection. So we keep drafts away. And sometimes we'll keep the baby in an enclosed sort of crib so that the baby can't catch that draft or get that convection where they're going to lose that heat. And then radiation. The nice thing about radiation, it can work in our favor. We can put the baby under a radiant lamp to keep them warm, especially if we're giving them a bath or doing, you know, some sort of care and we need to keep the baby warm. The bad part about the radiation is if we put the baby near a wall or a window where it's cold, the heat can transfer, the coldness can transfer to the baby and they can lose heat that way. You do have to do a full workup on the baby. So you need to know mom's history. Some of this you can get from the medical record. Any history of rubella, hepatitis, or substance abuse. Also, any HIV, group B, streptococcus you would want to know about. If she received any sort of antibiotics, or if she had any sort of infection like chorioamnitis, or medications like steroids. We would also want to know about prenatal care, and the list goes on and on. So anything that was out of the ordinary for mom that affected either the pregnancy or the birthing process. We're also looking at those anthropotic measurements, the length, the weight, the head size, the chest size, the baby's vital signs, color of the skin. All right, jaundice can be either physiological or pathological. You need to know this, okay? Physiological usually happens within the first 2 or 3 days, but not within the 24-hour period. So usually the baby is already born, a day or two goes by, the physiological jaundice sets in. It's usually by some sort of breakdown of the red blood cells, or the body's building up this extra bilirubin and it can't get rid of it for some reason. Pathological jaundice is usually some other issue going on. And then the size of the fontanelles, the head size, any sort of abnormalities can also dictate some sort of difficulty with the child. So what would we expect to see? All right, the head circumference of 33 to 37. Chest circumference, you see it's just a little bit smaller there, a couple centimeters smaller, 30 to 33. We talked about that on the test question. The weight, 2,500 to 4,000 grams. And the length, 45 to 55 centimeters. Vital signs, temperature, 97 and 99, depending on how we take it. Apical pulse, 110 to 160. Again, once the baby's born, it's probably going to level out to about 120, 130. And then those respirations of 30 to 60, slightly irregular. The chest should still be symmetrical. Okay. We shouldn't see any gasping, any sort of retractions, anything like that. And we might see some short periods of apnea as long as they don't exceed 15 seconds. All right, the face, it will vary with age and gender. The baby might have full cheeks. All right, if they have a problem, you may see some sort of paralysis, some sort of nevus flammis or nevus vasculus. Again, these are things that happen on the skin. We'll talk a little bit more about them as we go along. The head, okay, things that we would see wrong with that would be microcephaly, it's too small, macrocephaly, it's too big, or the enlarged fontanelles. Now remember, fontanelles, right? Anterior, posterior. Anterior closes 4 to 6 months, right? When? Anterior, when does it close? I'm sorry, that's wrong. It's 4 to 6 centimeters in size. Diamond shape, when does it close?
12 to 18.
Okay. Posterior is going to be smaller, right? 0.5 to about 1 centimeter. And what shape is it going to have?
Triangle.
Triangular.
Triangular. Okay. And you should also know when that is set to close. Nose, so it should be in line, midline, narrow. The baby, it should be open so the baby can smell. We're looking for any sort of malformation or blockages. In the mouth, same thing, a line, midline, symmetric, intact with the soft and hard palate. In there, we look for things like Epstein pearls, erupted precocious, well, they won't have any teeth, but if it were an older child, but usually you don't see infants born with teeth. There have been some. Most of the time you don't. And thrush, all right, which would represent some sort of fungal infection. Also with the mouth, we always look for like the cleft palate or cleft lip, because that the babies can be born with that as well. The neck, is it short? Is it creased? Does it move freely? Is the baby able to hold the head in midline? So we'll see that short or that creased neck in some babies that have issues like Down syndrome. Is there any restricted movement? Do they have any fractures of the shoulders? And again, you can see that in a baby that had either some sort of dystocia, the baby's too big, maybe the baby wasn't positioned right. We look at the eyes, they should be clear, symmetrical, in line with the ears. We look for things like chemical conjunctivitis or any sort of subconjunctival hemorrhages. The ears should be soft and pliable, and when you grab them and bend them, they should quickly go back in place. If they're low set or if there's any hearing loss, then we have to look at other potential for abnormalities. Again, the ears tell us a lot about different congenital issues in children because the ears are developed at the same time as the kidneys. So typically one indicates that there's a problem in the body with something else. The chest will be round, symmetrical, smaller than the head. And you may see some nipple engorgement or some whitish discharge, especially in those older babies. The abdomen should be protuberant, contour, soft. It should have 3 vessels in the umbilical cord. A problem would be indicated if it was distended or there were only 2 vessels in the umbilical cord. And then genitals we talked about. And you're also looking at the hips for any sort of dislocation, any sort of tufts or dimples. What would a tuft indicate? What would that hair tuft indicate?
Spina bifida.
Okay. Spina bifida. Also, you're looking at the neurological status, like their alertness, their posture, their muscle tone, their reflexes. All right, so the eyes, you're checking the color for the red reflex, looking for any potential subconjunctival hemorrhages from the birth trauma. Any chemical conjunctivitis from a reaction to the eye prophylactis that we gave, which is what?
Erythromycin.
Okay, for those ladies who might have gonorrhea or chlamydia. We're looking at the ears. We're looking at the pinna to see if it lines up with the eyes. If any loud noises elicits the startle reflex. If it doesn't elicit the startle reflex, what would we want to do?
Check the hearing.
Check that hearing. Good. Flexible pinna with cartilage present. If the baby's older, how's that pinna going to be? And that cartilage. Stiffer, right? All right, we're looking at the nose. These babies breathe through the nose, so we don't want any discharge or any blockage in there. The baby has a natural reflex to sneeze to clear the nostrils. Sometimes the bridge may appear absent. They might have thin white nasal mucus discharge. Sometimes they can have milia on that nose too, right? What's that mean? Those little white
A
milk.
blockage of the nostril.
Well, milia would be the little white milk pimples. You know what I'm talking about? How many of y'all ever seen little white bumps on your baby's nose?
Yes, yes.
Okay, it looks like milk. It looks like somebody dripped milk on it. Look for signs of distress. So what kind of signs of distress would you see in this nose if the baby was having difficulty breathing?
Nose flaring.
Flaring. How many of you have ever seen it? It's really prominent when it happens. Like you can really see the nose will change shape. It'll like widen up and it will flare out. All right, so look for malformation and look for any flaring beyond that first few moments after birth. Here's the mouth. That's thrush there, by the way. So is the mucosa moist? Is the palate high and arched? Are there well-developed fat pads bilaterally? Those little cheeks we like to squeeze, right? Babies have those cute little fat cheeks. Everybody wants to pinch them, right? Does the baby have a sucking, rooting, gag, and extrusion reflex? So the sucking reflex you can usually easily trigger, right? Or the rooting with your finger. Just by putting it along the baby's cheek, the baby will usually direct the mouth towards that because like, ooh, something's touching me, it might be food. We look for Epstein, pearls, thrush, supernumerary teeth. That's the picture down there on the right. So some babies are born with this. Genitalia. Right, so for the female, we're looking at the edematous labia and clitoris. The labia majora are larger and surrounding the labia minora, the vernix between the labia. For the male, we have that urinary meatus at the tip of the glans, penis. Palpable testes in the scrotum. Large edematous pendulous scrotum with that rugae. Smegma beneath prepuce. Okay, I didn't read that one. And stream adequate on voiding. The chest should have a xiphoid process that's evident. The anterior, posterior, and lateral diameters will be equal. The chest movement will be synchronous bilaterally. And the nipples should be symmetrical. You might see something called witch's milk or enlarged breasts and accessory nipples. So this, a lot of times you're going to see in that older child or the child that has an issue. Check for the apical pulse, check for retractions, check for grunting. So if you see any sort of abnormalities, those are the things you got to look for. You can hear the baby grunt. It's very obvious. All right, you're looking for the three vessels in the umbilical cord. Dome-shaped abdomen or protunded. Abdominal respirations, you're checking. Soft palpation, well-formed umbilical cord with three vessels. The cord is dry at the base. The liver should be palpable about 2 to 3 centimeters below the right costal margin. Bilaterally, you'll have equal femoral pulses. Valve sounds within a couple hours of birth and voiding within 24 hours. And then that meconium will be passed between 24 and 48 hours of birth. Neuromuscular. The baby should be able to maintain a position of flexion. When prone, they should be able to turn the head side to side. They can hold their head back and in a horizontal plane when they're held prone. They have the ability to hold the head erect for a minute. You should see that moral reflex if you elicit either a loud noise or if you do that little test I was telling you about where you drop the baby a little bit. All right, if the baby was in distress, then you would see things like lack of tone, hypotonia, quivering, limp or flaccid extremities, or lack of flexion. So the extremities are extended or straightened. Clonic jerking and paralysis. These would be things of some sort of distress for the baby. All right, look at the extremities. This is where you're going to see that plantar crease in the top picture, okay? And then you see they're bending the baby's hand back, and then they'll bring that hand all the way forward towards the wrist. So they're looking at flexure, they're looking at tone, range of motion. Does the baby have all the limbs? Are the legs bowed? Are the feet flat? Or do they have some sort of little arch? They look at the sole and look at the creases. All right, that Vertex caseosa, remember that's that oily substance that's produced on the baby. It's protective of the skin. We don't take it off. It looks like cottage cheese. They can have something called stork bite or salmon bites. It's usually around the neck area, the eyelids, and this is a group of immature blood vessels, and they're visible when the baby's crying. They usually go away in about a year. They're called stork bites or salmon bites, salmon patches. The milia, which is what I was talking about a minute ago, that's usually found on the baby's nose, and it's going to look like milk, really. But they can also have them on the chin or the forehead. Usually goes away in 2 to 4 weeks. If you see these little white patches in the mouth, they're called Epstein pearls, and they usually happen around the gum area. The baby could also develop Mongolian spots. I'll show you a picture of that in a minute, where they have these blue or purple splotches. Sometimes it looks like somebody beat the baby. And it can happen in African American, Asian, Hispanic, and Indian newborns. Erythema toxicum. This is a newborn rash, and it can happen in all newborns. So you'll see little papules or pustules on the skin that look sort of like flea bites. And then the Harlequin sign. This is similar to what they say it looks like a clown face. So like one side of the face will be pale and the other side would be red. And this is caused by immature autoregulation of the blood. And it's usually seen in low birth weight babies, especially when we change positions with the baby. It doesn't require any intervention. It can last for up to 20 minutes. All right, so you see the Mongolian spots, the erythema toxicum, and then the baby on the bottom has a mark from the forceps that were used during surgery. During labor. All right, there's a picture of the stork bite or the nevy, port wine stain, and strawberry hemangioma. Some other variations that you will see are things like molding. All right, molding is when the baby has an elongated shape of the head, often compared to that of a cone head. And the head does this in order for the body to be able to pass through the birth canal. Usually resolves in about a week without any intervention. Remember, we have to pay attention to this when we're doing what?
Checking the length.
Checking the length of the baby. Because it can affect the length of the baby because we measure from head to toe. Caput succedan. This is edema on the scalp. It happens from pressure during that birth process. We usually see this in babies that were involved in a prolonged labor. It'll have soft tissue swelling, and there's poor borders. So you really can't see where it stops and starts. It will cross the suture line. You'll see pitting edema, sometimes petechiae and ecchymosis. The swelling will go away in about 3 days without treatment. And it usually happens with babies that, again, were in that prolonged labor, and a lot of times the vacuum was used. The vacuum will cause that caput where the cup was placed. So again, this is going to look like a cone head. The Cephala Hematoma is a collection of blood. All right, it's caused by pressure on the head and disruption of the vessels during birth. Usually occurs after prolonged labor and use of things like the forceps or the vacuum. It's usually well pronounced, so good borders around this. It doesn't cross the suture line. Okay, so Cephala hematomas stay at homa. They do not cross the suture line. Cephalatomas stay at homa. They do not cross the suture line, but they do develop blood inside that because it's a hematoma, right? So as that blood starts to be reabsorbed by the body, sometimes we will see an increase in bilirubin levels and jaundice in these babies. Now, they also could get jaundice with the caput succedaneum, but your author says it's not as often. It's fairly rare. We'll go into a little bit more detail about these on another slide, but you also can see microcephaly, which is a small head. This is attributed partially to Zika virus, but that's not the only reason. But we are seeing some Zika with these babies and developmental delays. And we know that Zika now is transferred in the sperm. All right, so mom gets pregnant from dad that has the Zika or has it in the sperm. We don't even know yet how long the Zika stays in the sperm, but it's a pretty long time. And then a microcephaly, a lot of times we see this from hydrocephalus, which is what?
Fluid accumulation in the head.
Okay. And then we have to pay attention to the fontanelles. If they're large, they're small, they're closed, any issues like that. Prolonged vaginal delivery and use of forceps and vacuums can cause swelling to the baby's scalp. All right, so if they get the caput succedaneum, it's a harmless condition. It does cross the suture line. Okay. The baby's head will look cone-shaped, and fluid builds up underneath the scalp, causing swelling. It usually happens on the top of the scalp. It's usually noticeable at birth. The scalp will feel spongy. Again, it does cross the suture line, and it will start to go down after birth. The Cephala hematoma stays at homa. It doesn't cross the suture line. It's underneath the scalp. It appears soon after birth. It does not cross the suture line of the bones on the head and located usually at the back of the head. It can take months to go away, and usually hyperbilirubinemia will occur after the breakdown of the red blood cells inside that hematoma. So difference between caput succedaeum and Cephala Hematoma. What's the differences?
One crosses the suture line.
Which
The
one?
hematoma
crosses the
doesn't.
suture? Which one
The
crosses the suture?
hematoma. Oh, the caput whatever.
Okay, the succedaeum crosses the suture line. It's on top of the scalp. Okay? It crosses the suture line, it's on top of the scalp, and it doesn't usually cause jaundice. It can, but it's not normally causing that. Okay? Cephala Hematoma stays at home, does not cross the suture lines. Happens underneath the scalp. Buildup of blood, which leads to reabsorption of those old red blood cells and that jaundice or that hyperbilirubinemia. Microcephaly, this is when the head is less than 10% of a normal size. It can be caused by failure of brain development. Baby may not have as many neurons, and that can reduce the brain volume and the size of the head. All right, it's not common, but it is associated with things like seizures, developmental delay, intellectual disabilities. Macrocephaly is a benign condition. It's a head with a circumference of more than 90% of normal. It's usually related to the hydrocephalus. And it could be an isolated anomaly or part of clinical signs of another anomaly. Okay, and it would include hydrocephalus and skeletal disorders such as achondroplasia. They can also develop something called craniosynostosis, and this is abnormal brain development where we have premature fusion of the cranial sutures, inhibition of cranial bone growth, and a small fontanelle or early fontanelle closure. And you usually see this in babies that have the microcephaly. All right, so with those fontanelles, more than 6 centimeters in the anterior diameter, bone to bone, we would be concerned about. All right, that's that front anterior fontanelle. It should be 4 to 6 centimeters at the largest diameter and diamond shape. Put the diamond in the front. All right, or more than 1 centimeter in diameter in the posterior fontanelle. That's that triangular shaped fontanelle at the back of the head. That can indicate a problem also. So changes in the fontanelles are likely associated with malnutrition, hydrocephaly, congenital hypothyroidism, and trisomy 13, 18, and 21. Now, babies don't usually survive trisomy 13 and 18. If they do, it's not for a very long period of time. And trisomy 21 is what?
Down syndrome.
Down
Down
syndrome.
syndrome. These babies have an extra chromosome, okay? That's your little indication there, trisomy. They have too many chromosomes. 3 instead of 2. All right, small or closed fontanelles, smaller than the normal anterior and posterior diameters, or fontanelles that are closed at birth. So we just talked about the craniosynostosis. And again, that's more associated with the microcephaly, where the cranial sutures are either fusing together too early, or you have these small fontanelles less than 1 centimeter in size. So if we have too much fluid there, it can cause increased intracranial pressure. So if we see a bulging fontanelle, we should worry about that. And if it's depressed, then we should monitor the baby for dehydration. Fontanelles should typically be flat. Primitive reflexes that we'll see in the baby are things like the tonic neck reflex, the Gallant reflex, the truncal incurvation, rooting reflex, parachute reflex, grasp reflex. Remember that a reflex is a reaction in our muscles, and it happens automatically in response to some stimuli. So certain movements or sensations should produce certain responses in those muscles. With the baby, the reflexes are tested and observed to evaluate for neurological function and development. If the reflex is absent or abnormal, past the age where the reflex is normally lost, or redevelopment of the reflex in an older child can indicate significant central nervous system damage, nerve trunk, or peripheral nerve trunk problems. Look at the baby's reflex to evaluate neurological function and development. So the moral reflex is normal for the infant, and it happens when they're startled or if they feel like they're falling. The baby will have a startled look. The arms will fling out sideways with the palms up and the thumbs flexed. Absence of the moral reflex in a newborn is abnormal and may indicate injury or disease. So the moral reflex should be in the baby until about 3 to 6 months. The stepping reflex, this is when you hold the baby up and in a standing like position. If you put their feet near the ground, they'll do something called a stepping reflex, where they move in like a stepping motion or a walking, and it's alternating flexion and extension with the soles of the feet. That should go on until about 1 to 2 months. The rooting reflex, this is from birth until about 4 to 6 months. And this is where the baby roots for the bottle. So if you touch like the side of the mouth with your finger, the baby's going to try to pull the mouth that way, looking for the nipple of the bottle. The Babinski reflex, this would be present at birth. Why does it disappear about 1 year old?
So that y'all can learn how to walk?
Well, not so they can learn how to walk, but the reason why it disappears around then is because they are starting to walk. So the muscles are now starting to develop, and that causes it to go away. When the baby doesn't have the muscles or the development there, it causes it to occur. So this is why you might see this response in an adult person who has a neurological problem, because they've lacked control of that area. All right, so a diminished response would indicate a neurological problem. So with this, you stroke the bottom of the baby's foot and the toes should fan out. The newborn also exists 2 grasp reflexes, the palmar grasp and the plantar grasp. They should be present until about 3 to 4 months of age. The truncal incurvation reflex, also known as the Gallant reflex, I would know this. They like to ask about this. This Gallant reflex. It disappears in a baby in about 4 weeks, and it's testing the T2S1 innervation. Lack of a response indicates a neurologic or a spinal cord problem. I'm going to send you guys the PowerPoints. If you look in the notes section on the PowerPoint, everybody knows how to get to the notes on the PowerPoint, right?
No.
You can't play it in slideshow. You just got to open it up as a regular PowerPoint. The notes are in the bottom. If you look at the bottom of your screen, when you have the PowerPoint open, you'll see something down there that says notes, comments. If you click on notes, that shows you the notes on the PowerPoint that I put in there. If you just play the PowerPoint like I'm doing right now in slideshow mode, you won't see the notes. You'll just see the slideshow. So you have to put the PowerPoint out of slideshow mode in order to see those notes. All right, but there's a link in there that will take you to a little video that'll tell you a little bit more about that Gallant reflex. So a lot of those reflexes will go away as the child grows. If the reflex is still present after the age when it should have disappeared, it would be considered a sign of brain or nervous system damage. Some reflexes that are normal in infants but abnormal in other groups would be the sucking reflex, the startle reflex, the step reflex. The tonic neck reflex occurs when the head of the child is relaxed and laying face up is moved side to side. The arm on the side where the head is facing reaches away from the body with the hand partly open. The hand on the side away from the face is flexed and the fist is tightly clenched. Turning the baby's face in the other direction reverses the position. The tonic neck position is described as fencer's position because it looks like a fencer's stance. For that Gallant reflex, this happens when you take and you stroke the baby's spine or you tap it while the baby lays on the stomach. The baby should twitch the hips towards the touch in a dancing-like movement. The grasp reflex, which occurs when you put a finger on the baby's open palm and the hand closes around the finger. The rooting reflex, when the baby's cheek is stroked, the baby will turn towards that side and begin to make sucking motions. The parachute reflex, this happens in a little bit older babies when we hold the baby upright and the baby's body is rotated to face forward, as in falling, the baby will extend the arms outward to break the fall, even though this reflex will appear long before the baby even starts to walk. So in other words, you have the baby sitting on your lap, facing towards like the wall or away from you. If you let that baby slide down and go in a motion where it's going to fall or it feels like it's going to fall, the baby should automatically put its hands out, even if it's nowhere near the age of walking. Blinking, sneezing, gagging, and coughing are protective reflexes. So they're elicited whenever we bring something close to the baby's eye, it'll blink. If the baby is given something irritating, or if we use a bulb syringe to suction, it'll gag or cough. And if we bring something irritant, some sort of irritant or irritation towards the nose, the baby will sneeze. So for the blinking reflex, the baby should blink the eyes when they're touched or when a sudden bright light appears. For the cough reflex, the baby should cough whenever the airway is stimulated. For the gag reflex, the baby should gag when the neck, throat, or the back of the mouth is stimulated. Sneezing reflex, the baby should sneeze whenever the passages are irritated of the nose. Yawn reflex, the baby should yawn when the body needs more oxygen. Infant reflexes can also occur in adults who have brain damage or stroke. So here's your post-term baby. All right, look at that skin. How it's peeling. Look at the creases in the foot. You see how it says they're all over the place? So make sure that mom is taught to avoid tub baths until the cord is fallen off. You should wear gloves because you could be exposed to mom's blood on the baby. So when you're doing that first initial cleanup on the baby, you need gloves on. All right, do it quickly, dry the baby thoroughly to prevent heat loss, and then keep the baby covered to prevent heat loss during the bath process. Circumcision. This is when we remove all or part of the foreskin or the prepuce of the penis. It's performed for a variety of reasons: medical, religious, cultural, and social. We do it for hygiene, medical reasons, but it is also the oldest known religious rite. In the Jewish faith, circumcision is performed by a mohel, or an ordained circumciser, on the 8th day after birth, if possible. The decision to circumcise the male newborn is often a social one, with the strongest factor being whether the newborn's father is himself circumcised. So with circumcision, what you'll see is when they ask questions, they'll ask questions about how to comfort the baby. They'll ask questions about care, whether or not the yellow little discharge you see is normal and you should remove it. They'll ask questions about if the baby has like some sort of abnormality, because what'll happen is sometimes when a baby is born like with epispadias or something like that, they'll wait to do the circumcision, because if they're going to do some sort of repair to the penis, they can remove that skin and use it to do the repair with, and then do the circumcision at the same time. So these are all things that you have to consider, especially if the child has any sort of abnormalities. You're always going to protect that cord during the diaper change. Make sure you put in alcohol, the dye, or the antimicrobial agent, depending on what your policy is. All right, and then on the next page, I think, is a whole list of what you would teach on one of these. This is for circumcision. Did somebody have a question?
I did, just about the yellow discharge. So should you remove it or?
We don't usually remove it.
Okay, so, and it's it's infection or?
No. We usually
Oh.
expect to see a little bit of yellowish. It's not like
Okay.
pure discharge that you would normally see.
Okay, thank you.
But we will have a little bit of discussion on that right here. All right, so this is going to tell you exactly what to do. All right, so after circumcision, we'll cover the penis with the petroleum jelly to keep it from sticking to the diaper. We'll assess for bleeding every 30 minutes or at least 2 hours. This is why you got to make sure the baby got wet.
The vitamin K?
Yes. Good. Make sure the baby is voided at least once since birth. Make sure they haven't eaten for an hour before the procedure. We will give parental consent. We do have to make sure we ID the baby. Daily, we would rinse soapy water over the area. Pat it dry. We'll document the first voiding to evaluate for any sort of obstruction or edema. We're putting that small amount of petroleum jelly. All right, and then we're going to fasten the diaper loosely over the penis, and we'll avoid putting the baby on his belly so that we don't have any friction there. Cord care. Sorry, let me go back to the previous slide. So that was the one that we did for the circumcision. I'm going to send you guys these slides anyway. All right, so cord care, we're also observing for bleeding, redness, drainage, any sort of odors. No tub baths till the cord is off. We're going to expose the cord to air so it can dry out. Make sure the diapers are folded underneath the cord so that we don't contaminate, and it helps to dry it. Make sure that we're looking at the color, okay? It should change from yellow to brown to black, and don't ever try to pull it or loosen it. It will fall off on its own naturally. All right, testing. Most common, PKU, hypothyroid, galactosemia, and sickle cell. We'll go through these in a minute. All right, timing depends on the test. For example, if we're testing for PKU, all right, the baby has to eat. All right, so it's going to take 24 hours. The baby has to eat. We got to wait 24 hours before we do this test. Screening for genetic and inborn errors would require a few drops of blood from the heel, and they're usually done right before discharge. All right, so PKU, we have to wait until at least 24 hours. All right, the baby's going to need some kind of protein, so they would get that from the breast milk or the formula. And we're looking for the PKU. All right, if they have a PKU problem, we're not going to give them breast milk. They're going to need special formula, and they're going to need a low PKU diet for life. Congenital hypothyroidism or creatinism happens if the thyroid gland doesn't migrate during the baby's development, and we have some sort of malformation or malfunction of the thyroid gland. Therefore, not enough thyroid hormones are being produced. The baby's body is not able to meet its metabolic and growth development. So with creatinism, we have severe hypothyroidism in the baby or the child, and it's usually a result of mom's own iodine deficiency. The baby may be at risk for hearing loss. So we have to make sure that the baby can hear, okay? And delays in identifying can affect the baby's ability to develop their language, their cognitive. If we can detect it before 3 months old, we can greatly improve the outcomes. It's mandatory in all states. Some of the risk factors for hearing loss would be things like having a cytomegalovirus or rubella or toxoplasmosis infection, any sort of anomalies to the face or the skull that would involve the ear or the ear canal, being born under 1,500 grams, so that, you know, low birth weight, any sort of infection that mom has or the baby may have after birth, head trauma, too much bilirubin. So this is why we have to make sure that we're treating that jaundice. Exposure to autotoxic drugs, okay? So this is those aminoglycosides, usually the ones that end in myosin. Gentamicin being one of the big ones they give to babies. Myosins never let you win. They're toxic to your kidneys and mostly your hearing. And then any sort of perinatal asphyxia. Galactosemia, this is where they have a deficiency in an enzyme that's produced in the liver, and that enzyme is used to convert galactose or the breakdown of lactose found in dairy products into glucose. The galactose accumulation will damage the vital organs. If these babies have this, they'll get soy milk, not breast milk. Sickle cell anemia, you should be familiar with this. This is a vaso-occlusive disorder caused by that sickled S. It can cause anemia, growth restrictions. It puts the baby at high risk for dehydration, infection, electrolyte imbalances. These babies are going to need things like antibiotics, and their blood can become thick, so we might have to dilute it. And then we would just want to make sure that all these were done before at least the baby goes home. All right. Transient Tachypnea, what is that? So we might see this in babies that are born C-section because
Right.
the fluid is not properly removed from the lungs. So it could be from a combination of things, but they don't get that vaginal squeeze. The lymph system isn't working. So how's that fluid removed? It's a couple of things, right? We have the vaginal squeeze. We have the release of some of those catecholamines and the endocrine system, okay? And then we have the lymph system. So the presence of those three things remove that fluid from the lungs. If it's not removed all the way or it's done too slow, the baby can develop this transient tachypnea, which is sort of like pulmonary edema. It can be present at birth or right after, and it's usually treated with low-dose oxygen therapy. So we have inadequate or delayed clearance of fluid in the lungs, causing the baby to develop pulmonary edema. Usually happens in the first few hours of birth, resolving within 72 hours. We're monitoring the baby for respiratory distress. And we might have a little difficulty in the beginning distinguishing whether it is this or respiratory distress or group B strep pneumonia. All right, but the symptoms of transient tachypnea rarely last more than 72 hours. Management is totally supportive. As the retained lung fluid is absorbed by the lymphatic system, the baby's pulmonary status generally improves. So we focus on adequate oxygenation and determining if the respiratory manifestations appear to be resolving or persisting. We provide supportive care while the retained lung fluid is reabsorbed by the body. Physiological jaundice. So most of the time that's going to be caused by too much bilirubin. All right. Remember, we have direct and indirect bilirubin. First, the bilirubin, the indirect has to be broken down. It's fat soluble. It has to be broken down into water soluble and converted. Once it's broken down to that, then it's excreted mostly through the feces, but some through the urine. If that doesn't happen, then your baby develops jaundice, and the excessive bilirubin can cause brain damage and do permanent damage to the baby. We also have to monitor, and we'll go into that a little bit more in a second, hypoglycemia during the first 24 to 48 hours of life. As the baby transitions from intrauterine to extrauterine life, those glucose stores are typically lower. So feeding, early feeding, right, of the baby can prevent that. Hypoglycemia will affect about 40%. That's a pretty high number of all full-term newborns. And it's defined as that blood glucose level of less than 30 or a plasma concentration of less than 45. So we're going to breastfeed for jaundice. Okay, this is our interventions for jaundice. Physiological jaundice, which develops when?
It is right after birth.
Not
48
right
hours.
after birth. What develops within the first 24 hours? Physiologic or pathologic?
Pathologic.
Pathologic is in the first 24 hours. Physiologic will be after that. Okay?
2 to 3 days, right?
Yes. So we're going to frequent feeding, breast or formula, depending on what the baby's on. That's what we go with. Phototherapy, the lights can help break it down. What do you got to do when you put them under the lights?
Cover the eyes.
Cover the
Just the eyes
and genitals.
and genitals. Okay, assess for the jaundice whenever you do the vital signs, but no less than every 8 to 12 hours. We can do this by blanching the skin on the bridge of the nose, the sternum, or the forehead. So usually you'll see it on the babies, the eyes, the abdomen. If it's present, the blanched area will look yellow before the cap refill. If the newborn must be naked, turn them frequently to ensure maximum exposure of the skin. Side effects of phototherapy: loose stools, increased sensible water loss. What's that mean?
Dehydration.
Okay, where are they losing that water from?
Breathing.
The skin and breathing, yes, both. Transient rashes, potential retinal damage if the eyes are not covered. And then you're gonna do that kangarooing, that bonding, all that to prevent the separation. So hyperbilirubinemia is the most common cause of this, and it's caused from what? Most of the time. Breaking down to those red blood cells. Remember, the baby's blood cells when the baby's coming from mom into birth are what? Big or small?
Small.
They're big at birth, right? They're big first, but then as baby starts to transition in life, we get more red blood cells and they become smaller. So you're going to have some breaking down of those red blood cells. That's the number one reason for physiological jaundice. All right, it appears in full-term newborns. It has to be past that 24-hour mark when it first starts to show. Peaks at around 72 hours, resolves 5 to 7 days. All right, for the transient tachypnea, now what is this? What is this transient tachypnea?
We tell us about children born to C-section mothers.
Okay, most of the time it happens to the C-section mothers, not always. What's the main cause of it?
Is it the fluid?
Mhm.
The fluid in the lungs.
Okay, the fluid's not leaving the lungs quick enough. It's not being reabsorbed by the lymph nodes. It didn't get squeezed out during that vaginal push, and the endocrine system didn't take care of it. So now we have this increase in respirations, right? Above 60, because 60 would be normal, right? We're going to treat it with oxygen, warmth, monitoring that respiratory status, and allowing time for the pulmonary capillaries and the lymphatics to remove the remaining fluid. Because right now the baby's experiencing pulmonary edema. So it's going to affect their ability to perfuse and exchange gas, right? Hypoglycemia. What do you want to see in the baby? Now, besides getting hypoglycemia from just the blood sugar dropping, what else could lead to hypoglycemia in these babies?
Hypothermia.
Okay, cold stress, right? Which is really caused by that hypothermia because the baby has limited glucose stores. They don't shiver and they have to use that brown fat up. When they use that brown fat, it's going to increase metabolism. It's going to increase the use of the glucose in the body. They have those limited stores, and so they can become hypoglycemic during this cold stress issue. All right, signs of hypoglycemia: jitteriness, lethargy, poor feeding. Those are the things you're going to see. Who's at risk? Babies born to a mom that has gestational diabetes or she's a diabetic. Premature babies. Babies that have intrauterine growth restriction. Babies born with sepsis. Babies who experience some sort of asphyxic event. Babies with hypothermia or cold stress. Polycythemia, what's that?
High blood count.
Okay, high red
Increased
cell
red
blood,
blood cell.
high red cell blood count. They have an excessive amount of red blood cells. Usually we treat this with either phlebotomy or by removing some of the blood cells, or we have to give lots of fluids because the blood gets really thick. And then endocrine deficiencies, why would that put them at risk? Because your, thalamus, your pituitary gland is producing the ACTH that's stimulating your corticosteroids, right? Your epinephrine, your norepinephrine. So if that's not working, then it could affect treatment, sugar water, or feeding IV if severe. So typically we would feed early. All right, if the baby is below a certain amount, usually below 35, we do the IV. So we're looking at the glucose concentration of the plasma. If it's less than 45 in the first 72 hours of life. Newborns are going to be at a higher risk. We talked about those. Those are the ones that have moms with diabetes, those with intrauterine growth restriction, those that don't have adequate caloric intake, those with sepsis, hypothermia, or cold stress. Most of the time, these babies that experience the transient hypoglycemia are asymptomatic. All right, if they do have symptoms, it would be jitteriness, lethargy, cyanosis, weak cry, poor feeding, or a high-pitched cry. And if we don't treat it, the baby can have serious neurological effects, including learning disabilities and intellectual disabilities. So we're going to monitor for the signs of the hypoglycemia. We'll identify any baby that's at risk for it, because we want to monitor them better. Glucose screening should be performed on at-risk infants or those with clinical symptoms. Where would we check the glucose at?
In the hill.
Okay, in the hill. For bathing and hygiene, immediately after birth, dry the baby, remove any blood to minimize the risk of infection that could be transmitted from mom, like hepatitis B, herpes, or HIV. The nurse is going to wear what when she's bathing these babies?
Gloves.
Gloves. All right. Plain water on the baby's face and eyes, and then mild soap for the rest of the body. As far as the diaper area, you should be looking for the stools, all right? Remember, the stools will have those different patterns, right? You have that first stool, which is what?
The meconium.
What color is that?
Very
Green.
good.
Deacon. Green.
Okay, and then you have what stool?
You have the cool color.
You'll have that transition stool, right? And then you'll have a milk stool. You're also looking to make sure that you don't have any milk spilled on the baby. Why? What happens if milk goes into baby's neck folds? And you don't clean it.
Skin breakdown.
Okay, good, because all these products are high in sugar. Sugar will eat you alive. Urine characteristics. So the urine should be slightly amber in color. Baby should go through about 6 to 12 diapers a day. Look at those stool patterns we talked about. We'll probably talk about those a little bit more. And then make sure that the parents know that a rash that lasts longer than 3 days could be fungal and may need additional treatment. Also, what are you doing with that diaper to prevent any damage to the cord?
You
Put it
fold it
under the
Hold it
cord.
under.
Okay, pull it down, keep the cord out where it can air dry. The circumcision care, we're doing mild soap and water, petroleum jelly. Safety, okay, remember babies can roll. Don't ever leave them unattended anywhere, even if they're a newborn. All right, so they should have emergency numbers, poison control. They should be aware of the risk for aspiration, not leaving the child alone, keeping the child on their back, and washing their hands before they do formula or other things for the baby. Prevent the abduction. All right, they shouldn't leave the baby alone in any cars. They do this all the time with the car running. Make sure they're following the rules of the nursery, feeding, visiting hours, any security policies, those ID bracelets, and then car seats. They got to have a car seat to go home. Do not release any newborn unless the parents have a car seat. Rear facing for most infants up to 2 years. Babies need to sleep. So their sleep pattern, usually about 15 hours a day, 2 to 4 hours at a time. And they don't sleep through the night because they get hungry. All right, belly small, the food that's in there isn't going to last long. And then, of course, you're promoting bonding and you're watching to see if mom and dad are appropriately bonding with that baby, because you don't want to send that baby home to a monster. Physiological needs, calories. You need to know this. Okay, caloric needs 110 to 120 calorie per kilogram per body weight. Milk and breast formula have about 20 calories per ounces. Fluid requirements. For this baby, 100 to 150 mLs per kilogram a day, and most of that is already met through breast or bottle feeding. We don't give babies extra water. Why?
They're basically made up of water.
Okay, but that's not really the reason. Remember, their stomach's small. So if I wanted you to lose weight, what's one of the methods that I might use? I might have you drink like 2 or 3 glasses of water before you eat a meal. Why?
It fills them up.
Oh,
Pre-fills the stop.
Yeah, to
Low
fill you.
calories.
So I'm filling you up with water, which has no nutritional value. You also have to make sure the baby can suck and swallow. The baby can develop something called esophageal atresia. What's that? Pediatric nurses. I know you had this probably on the second exam. Yes, no, maybe so. So the baby's esophagus doesn't connect. So when they eat, they will choke, they'll have cyanosis, they'll cough. When that happens, you have to stop feeding the baby right away, immediately. So you're evaluating their ability to eat, swallow, and then frequency. So most babies are on a demand schedule. They're allowed to eat when they wake up. And we encourage mom to feed that baby every 2 to 4 hours and when the baby wakes up during the night for the first few days after birth. Breast milk is universally recognized as unequaled form of nourishment for the infant for the first 6 months of life. It provides a lot of benefits to the child, right? It can provide immunity because what's the number one thing in breast milk? IgA, right? Talked about that last week, the IgA in the breast milk. Also, the baby could develop something called necrotizing enterocolitis. We see that typically less in babies that are breastfeeding. Remember, that's a death sentence for the baby. We also see lower incidences of inflammatory bowel disease, type 2 diabetes, asthma, and obesity in these children. So we want to encourage breastfeeding. Mom can still breastfeed even when she has a mild illness, a cold, or the flu. However, it's currently not recommended if she has HIV or galactosemia that she breastfeed. So the composition of the milk starts out as colostrum. So it's going to be like this yellow, thick substance secreted during the first few days after birth. That's really high in protein, minerals, and fat-soluble vitamins. It also has this immunoglobulin A to protect the baby's GI tract against infections. And it works as a laxative, all right, to help the intestinal tract get rid of that meconium. The mother and the baby must be in a comfortable position to ensure that the breastfeeding is successful. So common positions would be the football position, the cross cradle, across the lap, or sideline. If we leave the baby alone on the mother's abdomen, the baby will scoot its way up, pushing with its feet as it smells that breast milk. It'll pull itself up with its arms and head, and it'll try to latch on to the nipple. Breastfeeding is not an inborn skill for a mom, okay? We don't just automatically know how to do this. We can do it successfully, but a lot of times we fail because we don't have the proper knowledge. So one, we have to show women how to properly breastfeed, because if the baby doesn't latch on right, then mom's going to get sore breasts and she's not going to want to do it. Mom also has to understand that the supply of milk is equal to the demand. So as long as the baby keeps sucking, he'll have plenty of milk. Mom also has to know that everything that she puts in her body has a potential to go into that milk. Can we store breast milk?
Yes.
So now not only can we store it, but we can also do what with it? We can donate it, right? We can donate it for babies that don't have the opportunity to get breast milk. We have to worry about sore nipples. You should know the difference between engorgement and mastitis. You are going to get tested on that. All right, so sometimes they'll experience things like cracked nipples, engorgement. Engorgement is when the breast overfills with milk. Or mastitis, where the breast itself is inflamed. We only use warm water to clean the nipples, not soap, and that prevents them from drying and cracking sometimes. All right, engorgement, that usually will happen around day 3 or 4 after the baby's born. It's usually self-limited. The baby will continue to nurse. This helps prevent mom's milk ducts from becoming plugged, which could then turn the engorgement into the mastitis. For engorgement, warm or hot showers to encourage the milk to release. Express some of the milk before they breastfeed manually. Lie back. That keeps the breast higher and will allow the fluid to follow the natural course of gravity. These these moms need a supportive bra 24 hours a day. They should massage the breasts from under the axilla towards the nipple. Increase the frequency of the feedings. You'll be tested on all these. You better know it. Keep the baby with them to facilitate frequent breastfeeding. Apply warm compresses before feeding. Stay relaxed while feeding. Stand in the shower and let the hot water hit the back to relax and release some milk. And then use a breast pump if the nursing or the manual expression is not effective. Mastitis or inflammation of the breast. This is going to cause flu-like symptoms, chills, fever, and malaise. Symptoms can occur before the development of the soreness, aching, or swelling, and redness in the breast. Usually happens in the upper outer quadrant, and it can occur in just one side. If the milk duct becomes blocked, causes inflammation, or through a cracked or damaged nipple. So this Staph aureus gets in that cracked or damaged nipple, and it usually comes from where?
From the skin of the mouth.
The mouth, baby's mouth. All right, treatment consists of rest, warm compresses, antibiotics, breast support, continued breastfeeding. So for both of them, we're going to do what? Feed the baby.
Breastfeed.
All right, explain to the mother it's important to keep the milk flowing in the infected breast, whether it's through nursing, manual expression, or with the pump. We use the Latch Method. This is to assess how well mom is doing with the breastfeeding. So we look at how well the baby latches. We listen for audible swallowing. Why? Make sure the baby's getting milk and not air, right? We look at mom's nipple because some nipples are going to be easier to attach to than others. Some people have these nice nipples that pop out, and other people have these nipples that are inverted or flat. The level of comfort and how much help mom actually needs for this. All right, during the first, an infant typically requires how many calories per kilogram per day during the first 3 months?
See?
Good. 110 to 120. Got to know that. What types of formula? Okay, so we have commercial formulas that come in powder, concentrate, easy to feed or ready to use. They're all similar in terms of nutritional content, but differ in expense. Mom may need assistance, okay? She may need assistance either in obtaining the formula or in how to feed, position the baby. They'll need education. And then eventually we'll wean from breastfeeding to a cup. All right, and that has advantages over weaning to a bottle because it eliminates the step of weaning first to a bottle and then to a cup. So really, when the baby's going off the breast, you want to start introducing them to a cup. A lot of these babies can't go to bed without the bottle. You don't want them sleeping with the bottle, right? Not good for their teeth. All right, so we're preparing mom for discharge. Make sure you are aware of the baseline knowledge and how to meet it. Think about your cultural concerns. When should mom follow up? Breastfeeding, we have to be careful, okay? It's not a form of birth control. What warning signs and symptoms should mom look for? So we're looking at the baby's weight. We're looking at the baby's stools, right? We can look at the fontanelles and the eyes on the baby to see if the baby's, We can do the weight on the baby to see if the baby's gaining adequately. We can count the diapers on the baby, right? That will tell us if the baby's getting enough hydration or enough food. For mom, we can look at the breast. You know, are they cracked? Is there any redness, inflammation? Okay, or are they just swollen? Is it unilateral or bilateral? Sometimes with engorgement, you'll see it bilaterally, but with the mastitis, you might only see it where? On one breast, right? And a lot of times it'll be that breast with that cracked nipple where what got into it? Staph aureus from that baby's mouth. Guarantee you might see stuff about this on the test. Things to remember. How do we treat the mastitis versus the
Engorgement.
So first of all, engorgement's going to feel what?
Like full and heavy.
Full, sore, swollen. So what do we want to do for this mom?
Hot showers. Face in the
Hot
back.
showers to let the milk come down. What else?
Warm compresses.
Okay, warm compresses. What else?
Continue expressing milk.
Okay, express that milk. Either feed the baby, use the pump, manually express it. Whatever you got to do, let's keep getting it out, because if we don't get the milk out, what's going to happen?
Mastitis.
Okay, mastitis from the plugged duct. Good. What about supportive care for mom for the
Like a 20
engorgement?
a bra
Tight-fitting
24
bra.
hours.
Okay, that's supportive bra. Now, another thing that we do is cabbage leaves. Okay, you can put cabbage leaves in the freezer or tea bags, and they'll help. And you can put those on the breast. You will see it on tests sometimes. Okay, for mastitis,
Miss
what's
Loach, one
mom going to
question.
present like?
Do you still feed the baby when you're taking antibiotics?
Yes.
Okay.
So for mastitis, they're going to take antibiotics. What are they going to feel like?
The flu?
Okay, tired, flu, cold-like symptoms. She can still feed the baby, right?
Yes.
Does it happen to one breast or both breasts?
Most of the time, one.
Okay, and it can be caused by that blocked
Staph
duct,
The
right?
Staph aureus.
Okay, the Staph aureus from the baby's mouth and that blocked duct. And then you already talked about the antibiotics for it. All right, that was 18. Just going to stop recording here and then start back up, just because I want to put these chapters each